So I think one of the few things that there is ample consensus in the field of myeloma, at least if you talk to physicians, investigators, is that this notion that we should define patients for clinical trials or for regulatory approvals based on lines of therapy is not a good proposition, in part because it's a very dynamic field. And what patients were treated on first and second line therapy 5-10 years ago is very different from what they receive nowadays. So there has been a few retrospective observational studies that show that actually drug class refractoriness rather than number of prior lines of therapy are the better predictive outcome for patients. So what we did is we look at our own institution. There's a single institution analysis from UAB. We got over 70 patients being observed through multiple subsequent lines of therapy. We exclude experimental agents to keep it cleaner. And we track progression-free survival and chances of response. So as you would expect, as you get refractoriness to more classes of agents, the chances of response and the progression-free survival does decline. And the same with lines of therapy. But when you adjust for refractoriness, number of lines of therapy no longer matters. So essentially, if you gotta use one or the other, the fact that you're accounting for refractoriness to other therapies completely negates how many lines of therapy the patient had. We believe that is an eye-opener, that if we keep doing this of making patients eligible for therapies, either on trials or commercially available based on line of therapy, we are underserving a lot of patients who might reach refractoriness to 2 or 3 classes after 1, 2, or 3 lines of therapy and not have access to more promising agents on trials or commercially available that have been approved for patients with 4 or more prior lines of therapy.